You at the E-style question on amyotrophic lateral sclerosis? Question. A 55-year-old man presents to the clinic with progressive muscle weakness over the past 6 months. He first noticed weakness in his right hand, which has now spread to both arms. His wife reports that he has been experiencing difficulty swallowing and occasional slurred speech. He does not have sensory deficits or bowel bladder dysfunction. On physical examination, there is muscle atrophy and fasciculations in the upper extremities. Spasticity and hyperreflexia are noted in the lower extremities. Sensory examination is normal. Which of the following is the most likely diagnosis? A. Multiple sclerosis. B. Guillain-Barré syndrome. C. Amyotrophic lateral sclerosis. D. Myasthenia gravis. E. Syringomyelia. Answer C. Amyotrophic lateral sclerosis ALS. Explanation. This patient presents with progressive muscle weakness, bulbar symptoms, dysphagia, dysarthria, and a combination of upper and lower motor neuron, UMN and LMN signs, which is characteristic of amyotrophic lateral sclerosis ALS. Key clinical features of ALS: upper motor neuron UN degeneration, spasticity, hyperreflexia, Babinski sign, lower motor neuron LMN degeneration, muscle atrophy, fasciculations, weakness, progressive weakness that spreads asymmetrically, often begins in limbs, bulbar symptoms, dysarthria, dysphagia, difficulty chewing due to brainstem involvement. No sensory deficits, distinguishing it from other neurodegenerative or demyelinating diseases. Pathophysiology. ALS involves degeneration of both UMNs, corticospinal tract, and LMNs, anterior horn cells, and brainstem motor nuclei. In familial ALS, mutations in the SOD1 gene, superoxide dismutase 1, lead to misfolded protein aggregation, causing neuronal death. The disease is progressive and ultimately leads to respiratory failure, the most common cause of death. Why not the other options? Differential diagnosis. Key differences from ALS: multiple sclerosis, demyelinating disease with relapsing remitting course, sensory deficits, optic neuritis. B. Glenn syndrome, acute post-infectious ascending paralysis, LMN signs only, absent reflexes. D. Myasthenia gravis, fatigable muscle weakness, worsens with use, improves with rest, affects extraocular muscles, ptosis, diplopia. E. Syringomyelia, cape-like loss of pain and temperature sensation associated with cervical cord cavitation, LMN signs at the lesion level, no UMN involvement. Take-home point: amyotrophic lateral sclerosis, ALS, is a progressive neurodegenerative disease characterized by combined upper and lower motor neuron degeneration, often caused by mutations in the SOD1 gene in familial cases. It presents with asymmetric weakness, fasciculations, hyperreflexia, and bulbar symptoms, but no sensory loss. Would you like a follow-up question on ALS management or treatment options?